Good
All
idea.
right. Dr. Center, you want to take us away?
Yeah, so I don't know anything about what they're presenting to me today, but it looks like it's going to be an acid-base electrolyte case, so that's fun. And
Neither do we.
And so maybe we can have a couple people help with the discussion, and I'm going to do whatever Stephen Alon tells me to do, because that's what he told me. He said he's going to have to point me in the right direction or something.
Maybe. We'll see. So why don't we have Dr. Center's already introduced himself. Why don't we have our discussants introduce themselves as well?
All right. So hi again, everyone. I'm Drew. I'm I'm an M4 over at VCU School of Medicine, MCV for all the other hours. Just submitted ERAS and excited to be back on.
All right, great.
Yes, I am Hung, and I'm a final year student in Vietnam. I have discussed 2 weeks before, and so sorry to come back too soon. But I think there are some event in American, so I think there's no people sign up, so I decided to discuss today.
Thanks for joining back. All right. Well, I will kick us off with a little bit of history in the BMP, and I'll let you guys take it away. So this is a 62-year-old man who comes in with acute onset of aphasia and the BMP that you guys see below. So I will put it to the discussants. Han, why don't you take it away with what you see?
Yes, the first thing that is the sodium is in the normal range, but there's a hypokalemia. The chloride and the 33, I think, is a pi cap. The pi cap is quite high, so there may be some metabolic alkalosis or maybe a respiratory acidosis here. The BUN is 17, and the normal creatinine, but the glucose is quite high. When there's a hypokalemia, I think this is not a severe hypokalemia, and the thing I want to check is the cause that cause hypokalemia. Maybe this due to the GI loss, renal loss, and any cause that shift the potassium and that. Yes, the first I want to check more about her medication. Any surgery he has done before. And yes, that's my thoughts.
Yeah, that's great. Drew, anything to add? I saw something in the chat, but why don't you tell us?
So just a couple of things. One is that if you look over to the right, that glucose is also a bit high. So although usually when you think of low potassium, you would think of high insulin state or hypoglycemia or something like that. But the main thing that I'm worried about is that high bicarb. I agree with Han that probably not. GI losses are probably lower down the list of our differential, given that his chlorides looks relatively okay. But I'd want to get a VBG to see, or check his breathing at the very least to see how much CO2 he's blowing off.
Okay, so this is a great start. There are a couple little things here that are intriguing. The first is the BUN to creatinine ratio. And the BUN to creatinine ratio is about 25. It makes me wonder if the patient's volume contracted. So a nice story would be volume contraction something that's causing volume contraction that causes both hypokalemia and metabolic alkalosis. That's sort of a classic story. I always mention the anion gap when I look at these things, and the anion gap here is 9. So we probably have a slightly low albumin. The glucose is high. We haven't been told that the patient is diabetic. And so we'd like to know whether or not the patient's diabetic and whether the patient has been on medications. I agree with Drew very much that I want to be sure that I'm dealing with a metabolic alkalosis and that I'm not dealing with compensation for respiratory acidosis, but then I still have to consider the hypokalemia. I've talked about this a number of times, but it's always worthwhile to think about hypokalemia in relationship to the acid-base status. So there's hypokalemia with normal gap acidosis, and that's usually from diarrhea, lower GI losses. There's hypokalemia with metabolic alkalosis, and that could be from upper GI losses or from diuretics, especially furosemide or one of the loop diuretics, but any persistent diuresis can cause that. You can also get that from anything that is in the aldose system. So we have to keep in the back of our minds every time we see a metabolic alkalosis and hypokalemia, could this be an increased aldosterone state? And there are a variety of ways you can get to an increased aldosterone state. What is confusing now is I can't put any of these together with acute aphasia. There's also hypokalemia with a normal acid-base status, and that's usually some kind of hypokalemic periodic paralysis. That's much less common in our routine cases, but whenever we have unremarkable labs, everything is on the table because they're purposely giving us something to make us stretch. So I love the idea about getting some more history, knowing medications. Are there any medications? Is he taking anything over the counter? So, for example, I've had cases presented to me before where people were trying to treat a problem with licorice oil. And licorice oil will have glyceric acid and act like an aldo overdose. And that actually can cause someone to have hypokalemic paralysis. You can get it from chewing tobacco, especially red man tobacco is flavored with glyceric acid. That's really unusual, but you have to both chew the tobacco and then swallow the juice, which is pretty disgusting. But there are case reports, so you need to be aware of that. It could be that the patient is obsessed with licorice and gets licorice from over the country. It's unlikely that this is a congenital hypokalemic metabolic alkalosis. Why would that present all of a sudden at 62? But none of this explains acute aphasia. None of this explains acute aphasia. So we're going to have to worry about that later on. So we want to know the meds, his underlying diagnoses, those kinds of things, and a VBG or an ABG. Either one would be fine.
Sure. So I think all of those are great questions. So I'll start with his medications. So he takes amlodipine, lisinopril, carvedilol, as well as insulin and metformin, and then oxycodone for back pain. He does not like licorice very much. And then as far as his medical history, so he's got pretty challenging to control hypertension, and he has metastatic prostate cancer with lytic bone lesions, and diabetes.
Do we know how long he's had diabetes?
He's had diabetes for about 10 years now.
So just as a point, I always like to know how long someone's had diabetes to know whether or not to consider complications of diabetes. If someone's had diabetes for a year or two, for example, gastroparesis probably doesn't come into play at 1 or 2 years. At 10 years, it might come into play. And certainly gastroparesis could be a reason for hypokalemic metabolic alkalosis. So that's been long enough. The prostate cancer with bone lesions, sort of like to know what the calcium is. But he's on a medicine that should make him hyperkalemic, right, Han?
I think the hypo medication is quite not related to the potassium concentration, but the messed up protein cancer that make me think of renal RTA, renal distal acidosis more.
Weekend update. That's good, man.
That'll
Did you hear
get
about
you.
So I think I didn't say it very well, Han. He's on a medicine that should cause a high potassium as opposed to low potassium. And which of those medicines should give us a high potassium if it's going to affect the potassium? Drew, maybe you can help her.
It's the lisinopril. It's supposed to block the renin-angiotensin-aldosterone system. So
Right. So normally with lisinopril, we worry about hyperkalemia, and normally with if he had diabetic nephropathy, and that's why it was nice to know that this is 10 years. But with a creatinine of 0.7, he probably does not have diabetic nephropathy yet. Now, a urinalysis, he might have early diabetic nephropathy, but he's unlikely to get into trouble with hyperkalemia. So we still need more history on how this aphasia started and whether he's been vomiting, but we still need the VBG.
Also
so urinalysis and a VBG would be really nice.
Right, and I also want a BP as well, just to see if his hypertension is still through the roof.
An exam is a good idea.
True.
Sure, great. So I'll give y'all all of that. So as far as his vitals, afebrile, heart rate is 105, BP is 260 over 140, respiratory rate 14, setting 99% on room air. As far as his blood gas, we got a VBG, showed a pH of 7.47, the CO2 of 47, and a bicarb of 33. And then as far as his urinalysis, his specific gravity, which I remembered this time, Dr. Centaur, was 1014, and his pH was 5, and it was otherwise bland.
So, Stephen, real quick, just wanted to make sure. You said his BP was 260 over 80?
Yeah, sorry, 260 over 140.
Over 140. Yeah, this guy needs a CT, non-con head CT stat, because that is a blood pressure that I am not willing to tolerate, given that it's that high. Because that acute aphasia makes me think that there's a brain bleed going on. As for the gas, don't know. I'm trying to remember the numbers that you gave, but he's alkalotic. His CO2 is relatively normal, so this looks more like a metabolic alkalosis to me. And then as for the UA, again, it doesn't look like there's anything wrong with his kidneys. Nothing to suggest that his kidneys are the issue.
Okay, just to be picky, that's a high PCO2, and that's even a high PCO2. Is this a VBG?
It is.
Yeah, it's a VBG.
So that's still high, but that's what you would expect with a metabolic alkalosis, that he's compensating and hypoventilating.
Okay.
The urinalysis number one tells us that the kidneys are working, and number two, it tells us that they're concentrating the urine. So our hypothesis of the BUN to creatinine ratio, I mean, it could have been a GI bleed, but it's probably some volume contraction. The question is, how long does he have this acute aphasia, and what kind of state was he in before that? Is he volume contracted? Has he had any vomiting? Those are all questions that we would go back and try to check on. Has he had decreased oral intake? These are all the things you think about. And it's a little bit unusual to be on 3 medicines for your blood pressure and none of them is a diuretic. Has he ever been on a diuretic? Does he have extra diuretic at home that he's sneaking? Stuff like that.
Mhm.
But it does look like hypertensive emergency. I'm fairly cavalier about hypertension unless there's signs of an emergency. And I think, as Drew pointed out, we have to assume this is a hypertensive urgency with acute aphasia. And so he should not be on the floor. The other thing that's remarkable, and I know the clinical problem solvers talk about this all the time, he's tachycardic. And that's just, he's in an inflammatory state. This guy's really, really sick.
Right. Completely forgot about that. I've been working with little kiddos for so long that heart rate didn't jump my alarms.
Yeah. So some people say anything over 90 is tachycardic. Everybody says anything over 100 is tachycardic. I'll give you tachycardia at 90 most of the time. And to have that blood pressure, if he's taking his medicines. Now we have to find out whether or not he's having any trouble with his medicines.
Mhm.
When you have blood pressure this high, Han, how might that affect the brain?
The blood pressure can cause a stroke or hemorrhage. Yes.
Stroke or hemorrhage.
Yes.
And the chat has another neurological complication that you have to worry about. Usually we don't look at the chat, but we're going to look at the chat because this is a cozy group.
Mhm.
So we have an excellent emergency medicine physician on. Travis, why don't you unmute yourself and talk about press for a second?
Well, when we talk about press, the posterior reversible encephalopathy, I don't know the exact mechanism, but it's basically, you get high blood pressure, confusion. I'm sure there's a breakdown in the blood-brain barrier causing some cerebral edema. It's one of the few hypertensive emergencies, and it's rare. It's not common. I mean, base rate hypertension, headache is not a hypertensive emergency. Most of the time people come into the ER and they're blaming headaches on their blood pressure when it's actually the opposite. Actually people who have migraines, it's actually protective for hypertension. Usually someone who has migraines, that population has less likely incidence of high blood pressure. But with press, they're confused, they're disoriented. Those are the ones that actually your radar should go off. Like, hey, I need to bring down their blood pressure, and they need a CT scan. And sometimes it doesn't always show up. You might need an MRI, but those are the ones that you're really looking to address their blood pressure.
So I'm not well schooled in press, so I'm going to lean on our chief residents now. Is aphasia one of the symptoms of press?
It would be an atypical syndrome. So the P in press is posterior. So it's typically posterior
Right.
involvement. So often you get occipital, you get, vision changes, blurry vision and so forth. You can have seizures and headache, but aphasia would be pretty atypical, though I'm sure it could happen.
So why don't we continue with the physical exam and see whether or not there's anything on neurological exam. But I wanted to go back and ask history about whether the patient had been vomiting at all, has their intake been like, etc.
Yeah, absolutely. So as far as his history, so he's had good intake, has not been vomiting, not been having bloody stool. As far as his medications, he has previously been on chlorthalidone, but did not tolerate it because of hypokalemia, and that's why he's no longer on a diuretic. As far as his aphasia, the story was he was doing well until the morning of. He woke up and he was having trouble producing speech. His wife was concerned and she brought him to the hospital. Did not complain of any weakness or numbness or tingling or trouble swallowing. And he's also been taking all of his blood pressure medications. So as far as his exam, he's not in any distress. He's sitting comfortably in bed. Cardiovascular exam is really unremarkable. Lungs are clear. His neuro exam, so his crown nerves are all intact. He has preserved strength and sensation throughout. He just has an expressive aphasia. He's having difficulty. He has very effortful speech. But what he can say, he does seem to be oriented. And sorry, go ahead.
The other set of patients that often get a hypokalemic metabolic alkalosis, in addition to diabetic patients, it looks like his diabetes is not wildly out of control. He comes in with a blood sugar 208. Alcoholics, people who drink a lot, deplete potassium, deplete magnesium, also deplete phosphate. And so you'd think about that as a cause of a hypokalemic metabolic alkalosis. So you'd have to get a behavioral history. Is he trying to treat himself with alcohol or anything like that?
Yeah, he doesn't drink alcohol at all.
So let's try to do a problem representation here that includes his numbers. So Han, are you good at problem representation?
Yes, 60, this is a 62-year-old male presenting with aphasia and hypokalemia and hyperpicap. He's on the medication that lisinopril and amlodipine. And the physical examination is notable for the tachycardia and hypertension, hypertension, and yes, yes, and this is my my bill.
Very nice, very nice. So what's strange here is he's on lisinopril, which usually protects you from hypokalemia. We used to see hypokalemia all the time. He was tried on chlorthalidone. Is that right?
Yes. And
chlorthalidone is great. It does cause hypokalemia, but usually lisinopril protects you from that. The fact that it doesn't is sort of a red flag in terms of working up the hypokalemia. So I would be very interested in the possibility of too much Aldo, because that Aldo would be a reason to have great difficulty controlling your blood pressure. It just so happens that yesterday evening on my podcast, Annals on Call, we released a podcast on the underdiagnosis of aldosteronism. Mm-hmm. A very interesting article that was in the Annals of Internal Medicine. And a very significant percentage of our patients with hypertension, and a greater incidence the worse the hypertension is. So even without any numbers, you don't have to have hypokalemia to think of aldosteronism. But anytime you get on 3 drugs and you're not controlling them, most experts would say that spironolactone is the next drug. and that you ought to go ahead and get a renin and aldo. And what the expert really tells us in this podcast is it's the low renin that is the big clue, that any aldo is inappropriate at this stage in someone who needs 3 drugs. So you would have to think about aldosterone as a possibility that could explain the blood pressure problems as well as the electrolyte problems. People mentioned that we ought to check a magnesium. 100% we have to check a magnesium. 100% we need to know what the calcium is. Is this really a magnesium problem? The patient, I think, with that blood pressure and acute aphasia needs imaging, and I think Drew said that we need imaging, and I think that's exactly right, because we want to see what we're dealing with. Are we dealing with a stroke? Are we dealing with something like press? And we need to get the blood pressure down, and I think that has to be done in an ICU because it's so high. Exactly what you're going to use to lower the blood pressure, I will leave to the ICU experts, because I'm not an ICU expert.
And I think the other thing that we'd probably want to do, but maybe this is a little bit lower down the line, is also get an ultrasound of his renal arteries. Because again, renovascular hypertension could be a
absolutely. And that's certainly true. You're 100% right, because that can also cause a hypokalemic metabolic alkalosis. So if we can do bedside ultrasound ourselves, but I think you're 100% right that those are 2 things we need to be looking for. It would be, as Dr. Wallace mentioned last week, if we just got routine ultrasound of the kidneys and noticed that one was remarkably smaller than the other. Now, I don't think that's going to happen with a creatinine of 0.7. Even though you only need one kidney, I still don't think that's going to happen. But it's a great thought. So can we get some of those things, Stephen?
Absolutely. So calcium is 9.4,
Good.
mag is 1.7, albumin is 3.4, and then he got a CT head without contrast as well as a CTA head and neck and a CT perfusion, which showed no acute abnormality, no flow limiting stenoses in his ICA or in his posterior circulation, and no perfusion defects.
So we don't see anything on the CT, and that doesn't mean he didn't have a small embolus or something like that. So he still, with his aphasia, he still could have something that shows up on an MRI that doesn't show up on a CT. But we should see if we're concerned about perfusion and press, we should have seen that on the CT, I think. Is that right?
Often, it's not. The MRI is certainly more sensitive. I don't know the exact numbers, but it certainly doesn't capture, CT does not capture all press.
Yeah. I think the main reason that I wanted a CT was to make sure that he wasn't bleeding.
Okay. While we're trying to figure all this out, do we need to give him potassium?
Question is, does he have any cardiac issues?
We don't have any history of cardiac.
Does he have any history of like coronary artery disease or heart failure or anything like that?
Nope.
All right. Because if there was, then the answer would have been yes.
So I'll kind of put this along. So he did get an MR brain, as Dr. Centaur alluded to, and that also showed no infarct or no other explanatory lesion. So he was admitted to the ICU, placed on a drip to lower his blood pressure, and his aphasia resolved. So he was deemed hypertensive emergency. And so he was discharged and he's following you up in clinic, and you still don't know what to make of his BMP and if this is all connected.
Well, let's just spend a minute talking about replacing potassium, because I think that's a really important topic. that a lot of people don't understand. And so what fluids would you give this guy? What fluids would you give this guy who's volume contracted, has a metabolic alkalosis, and how much potassium does he need, and how are you going to replete the potassium? And then what are you going to discharge him on given this severe blood pressure, and how are we going to work up? We have to assume secondary hypertension until we prove there's no secondary hypertension. So what would you estimate his potassium deficit is at this point? So now we're going to get to some real physiology. And this is really useful in adult medicine. I'm sure it's different, Drew, in pediatrics, but the principles are the same. So the first thing that I recommend is I'm pretty sure there's a podcast with Tony Brew on when do you need to replace potassium. And the cardiologists have been bent out of shape about keeping the potassium above 4 for a long time without any data. The data probably suggests that 3.5 to 4 is perfectly okay, but 3.1 is not okay. To go from 4 to 3, the last time that I looked this up in a textbook, in an article, you could have a deficit of 100 to 300 milliequivalents total body potassium. So you're going to have to give him quite a bit of potassium. So the question for our soon-to-be intern Drew is, how fast can you give potassium?
So usually when we give K over at MCV, it's max is like 40 milliequivalent runs. And
that you just spoke gibberish to me. What do you mean by that? Say it clearly.
So we'd give him so God, trying to think of exactly how this works now. So we'd be
this is useful before you're an intern, believe me.
Yeah.
Okay, so how fast can you give potassium by vein? You can give it faster orally.
I think it's 10 per hour in a peripheral and 20 if you get a PIC or a central line.
Okay, so there are two reasons you can't give potassium but so fast. One is it burns up the veins, and the other is it messes up the heart. You can go as high as 10 milliequivalents per hour with an IV, but I highly recommend you don't do that very often. I really stick to about 5 milliequivalents per hour, unless the patient has arrhythmias or something that I'm treating aggressively. Now, if the patient can take oral, then you can go ahead and give 40 milliequivalents every 4 to 6 hours, and you're going to replete it faster. It's just you can't give it but so fast IV. In the chat, they mentioned you could go as high as 20 per hour. That's only in an ICU with cardiac monitoring and nurses who know what to do, and a big line, and maybe even 2 big lines. So replacing potassium is tricky, and so you need to think about that. Now, metabolic alkalosis is interesting because your IV fluids are different for metabolic alkalosis than for almost everything else in 2020.
This is the one time where you can give normal saline.
This is the one time where that you should give normal saline, because apparently fixing a metabolic alkalosis has a lot to do with chloride. And so you really do want to give that chloride in this situation. Now, what's tricky is we can't use the blood pressure to give us a clue about how volume contracted the patient is. The patient's volume contracted, and yet they have hypertensive emergency. And I think we have some good evidence that their volume contracted. It would be very interesting to have an inferior vena cava ultrasound to look at that. But that's an aside. That's an aside. So I would have given the patient some fluid. There are a lot of different ways we could treat the blood pressure, and so many. There's been an active chat on this, but the patient's in clinic now. So I want to repeat the numbers in clinic, know what the patient was sent home on. I hope the patient was sent home on spironolactone. The patient should have been sent home on spironolactone because you have resistant hypertension. And spironolactone is the fourth drug every time. Stephen.
So, no, he was not. He was sent home on increased doses of his amlodipine and carvedilol.
May I go bang my head against the wall?
Same here.
Because I'm frustrated.
I'm seeing him in clinic, guys. I'm not in control.
I know, no, I'm not blaming you. No, this is just a general frustration. Why would you not put him on spironolactone? Did they order a renin? Do we have a renin Aldo coming back, and do we have a renal ultrasound and a Doppler coming back?
Yeah, so there was that. So they got a renal ultrasound with Dopplers, which showed, echogenic kidneys bilaterally, normal size, no hydro, and normal flow velocities. And then they got a renin and an Aldo, and both of those were essentially undetectable.
Both were undetectable.
Mm-hmm. And
undetectable as in low, or undetectable as in off the charts high?
Below the limit of detection.
Ooh.
Below the lower limit of detection. So, and then just for good measure, I can give you guys the BMP in clinic if you'd like.
Sure.
Okay. So sodium was 137, K was 3.0, chloride was 99, bicarb was 31, BUN was 13, creatinine was 0.7, and glucose was 193.
Did they replete potassium when he was in the hospital?
They did.
Magnesium. Was he given magnesium?
Mm-hmm. Yeah, they gave him some magnesium, and then they discharged him on some potassium supplements. His K never got above 3.3 while he was in the hospital.
K never got above 3.3. Mm-hmm. Did they send off any urine electrolytes?
Yeah, they did. So they got a urine potassium, which was 85, a urine sodium, which was less than 20, and then a urine chloride, which was 37.
So one of the things that I was taught back when I was an intern in 1975 and I was taught this on the GI service at the VA. There was a famous attending there, Reno Vlahovic, who Drew probably has not heard of, but he was the king of the GI ward at the VA for years and years. And what he taught us was that looking at the urine potassium and the urine sodium was a surrogate for mineralocorticoid activity. The context was, in order to get a good diuresis from someone who has ascites, you needed a natriuresis. And if they have secondary hyperaldo, they'll have these numbers. So there's strong mineralocorticoid activity, even though he has an aldo level that is low. This is strong mineralocorticoid activity because his urine potassium is so much higher than his urine sodium. Now, some people have looked at fancier ways to do it. Fancier ways to do this, the transtubular potassium gradient has been sort of debunked in the literature. But here, if the only way that you're going to be losing that much potassium and holding on to sodium is if there's something mineralocorticoid happening. Now, if it's not aldo that we're measuring, then we have to wonder, is it some other mineralocorticoid that is not being measured when we check our aldo? You can get that with congenital abnormalities. You can occasionally get that just with Cushing's disease. You can get enough mineralocorticoid activity, but it doesn't show up as aldo, and I don't really understand that. So now I'm really going down that pathway of everything that mimics primary aldosteronism since I got a nothing aldo level. I assume that nothing showed up in his adrenals when they did the ultrasound of his kidneys. If he had an adrenal mass, we should have seen it. So now I have to go to the books and go talk to the endocrinologists, go back and really see, does he like licorice and things like that? Has somebody snuck him licorice oil? Does he chew tobacco? All those kinds of things.
Or given that he's old enough, was he just not caught and he has maybe a mild-ish form of like a 17 hydroxylase deficiency?
Yeah. Well, so that's 100% right, Drew, and that's sort of where I was getting at. I didn't say it as well as you did. We have to look at all those things that'll cause hypertension and hypokalemia in the aldo aldo framework. Somebody said cortisol. Yeah, I'd get a cortisol level. You have hypertension and you have a mineralocorticoid like urine, sodium and urine potassium. Did everybody understand that explanation of the urine sodium and urine potassium? That you're not when you're hypokalemic, you should be holding on to potassium, and this guy, in the face of hypokalemia, is not able to hold on to potassium. That's a red flag. And he should be getting rid of sodium, and he's not getting rid of sodium. So cortisol level.
Yeah, cortisol level was 21.
21.
And what time?
Random. It was a random.
Oh, random.
What's normal?
Normal, at least at 6 a.m. at our lab, is like greater than 18.
So this is a little bit high. So
it's normal range.
Now we need to get, and in a situation where it shouldn't be high. So I think we need to go down the path of trying to work up what's going on with this cortisol. And so this is not Barter's, because Barter's you don't get hypertension, right? It's probably not Gittleman's because he didn't have profound hypomagnesemia. Somebody in the chat mentioned Little syndrome. That would be a possibility. I would put him on spironolactone. Somebody says triamterene. Some people would say Miloride. Miloride actually is doing really well for resistant hypertension. There's a lot of new data on that as an alternative to spironolactone if you don't want to use spironolactone. But I'd think about those, but I think I have to work up this cortisol.
Yeah, absolutely. So he came from an outside hospital, and as it happens, he had fragmented care, and there was one medication that was missing from his list to treat his metastatic prostate cancer, and that was abiraterone. It was abiraterone.
What?
So, pardon?
Oh, so what was it?
So we got a urine. We talked to endocrinology, and we got a urine-free cortisol and a urine-free cortisone. So his urine-free cortisol was normal. It was 10 mics for 24 hours, and then his free cortisone was 6 mics every 24 hours. And so what abiraterone does is a 17 beta dehydrogenase inhibitor, and so it prevents the conversion of cortisol to cortisone. Yeah, exactly. And so it's a cortisone mediated effect. And so we think that this was essentially a drug induced syndrome of apparent mineralocorticoid deficiency. And so,
mineralocorticoid deficiency or excess?
or excess, I'm sorry.
Yeah, excess.
Yeah. And the reason that I thought this case was so interesting is because in my mind, when I saw those labs, I immediately thought, oh, there's something wrong with Aldo. And when I got the low renin and low Aldo, it stimulated me to ask, well, I don't know what to do in those settings where it's the Aldo isn't high and the renin isn't low. And so I had to do some digging on that. There's other things to consider in prostate cancer, like ectopic ACTH secretion, but his ACTH was actually suppressed.
So I think so first of all, I hope that he has done well, and my guess is stopping. I didn't even know that I can't even say abiraterone.
I'm just guessing.
Abiraterone?
Something like that.
That medicine. I didn't even know it existed. But we deduced that there had to be a problem, that there had to be an Aldo-like problem, because we got the urine electrolytes, and the urine electrolytes told us this had to be in that mineralocorticoid pathway. I can now add this drug to my schema. It wasn't in my schema. What Drew said, little syndrome, taking Florinef, 9-alpha fludrohydrocortisone, all those things were in my list. The licorice stuff was all in my list. Now I get to add a new drug to that I didn't even know existed. As soon as I saw Arone and at the end of it, I said, well, that must be doing something to Aldo, because something had to be making him waste potassium. Mm-hmm. We were able to figure that out. And because we were able to figure that out, we were going to get to the right diagnosis sooner or later. Mm-hmm. Does that make sense to everybody?
Right. And the other thing too is that it also puts back into context his glucose of 208, because that could possibly be an effect of his high cortisol.
Right. So he my guess is his diabetes control had gotten worse. So that would have been another interesting thing. What was his hemoglobin A1C and what had been before, if he didn't have fragmented care.
Right.
I'm glad that the people who did not put him on spironolactone were not part of UAB, because I would have been really upset. I would have had to have lunch with one of the residents and teach them about resistant hypertension. Okay, so we have 5 to 10 minutes. I'd like several people to put in the chat the most important things they learned by going through this case. And I'm going to ask Han, what do you take away from this that is going to help you be a better physician? And then Drew, you get to go after that.
Yes, sir. The first thing I learned is that about the breast syndrome. I don't know this, and I haven't known it before. The second thing is the treatment of the hypokalemia. Because in the hospital I have a clinical rotation. They use all the formula that is based on the age and the sex of the patient to estimate the potassium deficit. The thing is, I think that is the new drug that is called the methyloid acid. And I learned from the schema from the skeleton group, and I didn't find this drug in the schema. And yes, yes, that is my and the first thing is when there's Cushing syndrome, they always say that is a hyponatremia is rare, but now I know if the patient have the hyponatremia, maybe this is a worsen prognosis of the patient. Yes, that is.
So, Han, I believe that Addison's gives you hyponatremia, but I don't think Cushing's usually does. And somebody correct me if I'm wrong on that one, but I don't remember Cushing's being on the list of things that causes hyponatremia. I think that's just Addison's disease. So that I think that's really helpful. What are your big lessons, Drew?
I guess the first big one is more management. For repleting potassium, you're able to go max that you should go is probably about 5 milliequivalents per hour in an IV, but PO you can give 40 every 4 to 6 hours. The other thing that that I guess I was looking into was that I sort of came into this thinking sort of in a more pediatric lens where things like congenital adrenal hyperplasias from blocks in the steroidogenesis pathway are things that are tested on the newborn screen. I did not know that abiraterone was another possible cause and a cause in adults.
I really like the way you said abiraterone. Now I know how to say it.
And then I guess the third thing is that, again, like Stephen had said, when I saw renin undetectably low, aldo undetectably low, my mind started thinking, okay, now what? And this has definitely expanded my schema on that front.
So what I hope everybody got out of it is how valuable these urine electrolytes were. In this situation, that told us what pathway we had to go down. Mm-hmm. Because the hypokalemia was really strange in someone who had an undetectable aldo. But that didn't take us away from the mineralocorticoid chain. And I think that's the big lesson. I think that's sort of, Stephen, did this discussion clarify some of the workup that you originally did and help? Why don't you share what you typed and what it all means to you?
Yeah, no, so I agree 100%. I thought the urine electrolytes were really compelling for suggesting an aldosterone-like molecule. And I was expecting a low renin and a high aldo because the most common cause of that would be primary hyperaldosteronism. And so when I was faced with a low, it caused me to have to do some research on what's the etiology there. And now I know if I ever see this again, to be thinking about licorice ingestion, Little syndrome, which is probably unlikely in a 62-year-old to present, and then syndrome of apparent mineralocorticoid excess, which is actually called SAME, S-A-M-E, which I think is a pretty cool abbreviation.
That is. Well, thank you so much for bringing us this case, because it made us think very carefully about how we would work this patient up. There are a lot of people who are very upset that this patient didn't get TPA, but that's sort of a side issue. I think it was just
the main issue.
Emergency. Travis, you were all upset about that, weren't you?
No, I think that case would be really, I would be nervous to take care of that patient too if he came in with, an acute stroke syndrome within the TPA window, and his blood pressure is that high and there's no hemorrhage. I mean, usually when people's blood pressure are that high, there's a hemorrhage there. I mean, there's very few things that cause hypertension of that degree. Hemorrhage is one of them. And if not, you're thinking, hey, if the person just has aphasia, their NIH score is not that high, but you have to think about what stroke syndrome is going to give you some debilitating post-stroke effect that, would be worth thrombolysing an NIH score of 1 or 2, and it would be not talking. So you would be thinking, hey, I need to at least try to bring this guy's blood pressure down. And in that case, you would be giving somebody a labetalol. And I can't think of a case off the top of my head that I've had where someone's blood pressure has been that high with an acute ischemic stroke. So it definitely would be nervous to give this guy to TPA, but giving him labetalol to see what it did to him. So that's just all I was thinking during the case.
Well, great. Next week, we're finally going to have the one and the only Dr. Rashida Talwani, and she is just superb, and she's going to go over an acute kidney injury case and how do you approach someone who comes in with a true, not subacute, but really acute kidney injury. Should be a lot.
They've already gotten fluids.
Yes, don't worry about it, Drew. You'll like this case.